Good afternoon, everybody. Thank you very much for coming on this webinar this afternoon, or if you're on US time this morning. As you can see, we've got some special guests up on the screen. This webinar is pretty much the conclusion of the successful webinars that we've been running throughout the lockdown period. And the feedback that we've been getting from the questionnaires has been extremely good. We will be carrying on various different webinars, but probably not as often now as a lot of people seem to have returned to work. As soon as the flying ban, etc., is lifted, we want to start with seminars and workshops. And the gentleman that you actually see on screen there will hopefully be very involved with them in the next few months and the next few years as well. So the purpose of this webinar is a round the table discussion. We've run so many, we just thought it would be a good opportunity, or I'd have to give credit to Dr. Silverman. It would be a good opportunity for everybody to ask questions. We've received a lot on email, but there is a lot that comes on as time goes by. So without further ado, what I'm going to do is I'm going to go through and introduce you to the guys. And then we'll bring up a PowerPoint presentation. On this presentation, you'll see from the first from the screen there, as attendees, you will notice a little hand on the panel. If you press on that hand, I know that you actually have a question. So at the minute, everybody is actually muted out. But when somebody actually presses the hand, we can unmute you individually, and then you can ask the question to the panel. They will give you their answers, and then we'll move on to the next one. But what I thought we'd actually do to start with, there are quite a few, well, people that would like to have attended, but due to work commitments couldn't. So they've sent on some videos and some questions. So we'll start off with them, and then we'll move on to the rest of you individually. So if you can just keep in mind to actually press the hand if you have a question. Or obviously, if you don't want to ask it verbally, you prefer to write it down, you'll see the questions box also on the right-hand side. So without further ado, I'd like to introduce you to our expert panel. We have two from the US, one from the UK, and one from Ireland. We'll start off with Dr. Robert Silverman. Rob's been doing quite a few webinars for us. He's a chiropractic doctor, he's a clinical nutritionist, national and international speaker, and author of Amazon's #1 bestseller, Inside Out Health. He's also the founder and CEO of Westchester Integrative Health Center. The ACA Sports Council named Dr. Silverman Sports Chiropractor of the Year in 2015. And his extensive list of educational accomplishments includes 6 different degrees in clinical nutrition. So welcome, Dr. Rob.
Thanks, Simon. Pleasure. Always a pleasure to be here with such an esteemed set of colleagues.
Exactly. And next, I'd like to move on to Dr. Kirk Gair. Kirk's based out of San Diego in California. He graduated in 1999, where he's classmate and friend of Dr. Datis Kazarian. I hope I pronounced that right.
Karajan.
Following graduation, I did I?
No, it's a little different, but that's right.
All right, okay. Forgive me for that one. Following graduation, he was trained in functional medicine and functional neurology, by one of the top experts in the world in those fields. Dr. Gair has been using our low-level lasers since 2004, and he's worked with Super Bowl champion players, World Series champions, Olympic gold medalists and world record holders, national and state champions, as well as weekend warriors. You have to maybe elaborate, Dr. Kirk, later on what a weekend warrior is.
Sure.
The techniques he has pioneered have earned him the reputation of a voodoo doctor because of how fast and how effective they are. And non-injured athletes regularly come to him just for sports performance enhancement, or is what we call in the UK and Europe prehab. So I'd like to also introduce you to Dr. Jake Cooke. Jake runs the neuromuscular clinic down there in Woking. He graduated from AACC in 2009, and he passed the American Chiropractic Neurology Board exams in 2014. He's currently doing a master's in MSK Neuroscience, and recently opened this clinic in Woking in Surrey, which focuses on patients with chronic pain and dizziness. We've known Jake for about 3 years now, since he got involved with our Accelerate laser, and I'm pleased to say that Jake has come on board with us as in our expert panel to share the experiences with you guys that he's actually seen himself. Last but not least, I'd like to introduce you to Mr. Robert Sullivan. Robert is a progressive reconstructive orthopedic podiatrist. He's known for thinking outside the box, encourages others to do the same. He has his clinic, the Middleton Laser Clinic, which is in County Cork. And as well as the other gentleman we've just talked about, he's a renowned domestic and international speaker for us and also independently. His special interests include pharmacology, diabetes-related conditions, fat cell management, non-thermal laser interventions, and he was the Dean of Education at one of Europe's leading podiatry institutes. So, guys, all four of you, very most welcome. We've all been looking forward to this for quite a while now. So without further ado, if it's okay with the four of you, we'll move on to some of the questions that we've actually received thus far, and that will give everybody an opportunity to either wave their hand or write their own questions down. We found the best way to actually play the first four were via links. So by all means, if anybody is actually having trouble viewing them or listening to them, let us know. So I'll play each one, and then we'll go straight to the panel to see what their thoughts are, and then we'll, as time goes by, we'll move on to the next one. So here's the first one. It's from Andrew Jackson. He's a Erchonia PL Touch owner. He owns Chiropractic Health Centres, which is down in Stockport in sort of the Cheshire area, quite close to Manchester. So let me bring up Andrew's video.
This question is for the panel. My name is Andrew Jackson. I'm a chiropractor. I've been using your Erchonia laser for a while for my colleagues. I wondered if you had maybe a standard type protocol which you guys have maybe decided upon for improving vagus function. Obviously, most of our patients are quite sympathetically dominant. So I'm just wondering whether or not you had a protocol for that, or is it very subjective, and as most of our patients are all different. I can understand that, but if you can just put your heads together and maybe give me some sort of answer, that'd be brilliant. So I hope you guys have a great panel. I've got to look after the kids as usual. So thanks very much. Take care. Have a good seminar, guys. Bye.
Vagus nerve. I'm all over it. I think
Absolutely.
I'm perspiring. No pun intended.
Yeah, I was about to say, I use Robert Silverman's protocols. I'm just gonna turn my head over to his screen and watch whatever he has to say.
No, you guys all have protocols, and what's great is you all have different protocols which open options. So he did say, I think, that he had a PL touch. So my preference or my strong suggestion would be an EVRL. So I have him here because I saw some of these in the middle of the night. So here's the EVRL. The difference between the PL touch and EVRL is, as you guys all know, the EVRL offers both the violet and the red laser. For me, I like adding the violet light to use for vagus nerve stimulation. In a nutshell, vagus nerve, medulla oblongata down through the transverse colon. So much literature speaking to the idea of the stimulation. Just off the presses yesterday, vagus nerve stimulation helped ameliorate COVID-19 respiratory symptoms. So, we're in this health pandemic or coming out of it, wherever you want to talk about. We're talking about vagus nerve. Vagus nerve enabling you to connect the gut to the brain and the brain to the gut, parasympathetic and sympathetic. So he wants a standard protocol. I'm trying to do it quick because we got a ton of questions and we got some great colleagues that want to chime in also. So real simple, I'm just going to show you one time. I'm not trying to make it too hands-on. Medulla oblongata with the violet light. Again, I prefer the violet down through the transverse colon, 3 to 5 waves up and down. Each side. When I say vagus nerve, I'm saying it sounds like it's singular. Vagus nerve is plural. There's one on each side. And then I take the red and the violet laser, put it right in the auricular area. Now, the auricular is great. They talked about the auricular, stimulating the auricular portion of the vagus for autism. also a lot of good health benefits. I know Dr. Sullivan sometimes does the violet and the red. I'm sure that that works. I just happen to go with the violet. I just don't necessarily like the red light by itself. And here's the reason. I did HRV, and everybody's got a different patient set, going to find something different. But what I found was HRV increased using the violet light. The bottom line and the overall theme when we talk about laser, and this is the new 35,000 foot view, is that a laser is electromagnetic transfer, energy. So we're doing energy. It's that photon energy. That's the new, it's not the new big thing, it's the new position that we have. So for me, vagus nerve, violet light. If I know Dr. Sullivan may do violet and red, violet light down through this particular area, 3 to 5, 30 seconds each. Auricular vagus nerve, 30 seconds each side, both red and violet.
Yeah, I love that protocol. That's great. What I would also do in my office is we also stack it with some vagus nerve exercises while we have the laser on. So we'll do some simple ones I learned from Dr. Karajian, which is just have the patient take a little water, hold it in their mouth, and tilt their head back and try to gargle as hard as they can for up to a minute. We'll do that, or we'll stimulate the gag reflex. That's while we have the laser simultaneously applied over the vagus nerve.
Rob Sullivan.
Can you hear me now?
There we go. Yeah.
Yep, fine, Rob. Yeah.
I think for me, I'm the non-chiropractor of the bunch, so I kind of approach things a little bit, I suppose, differently. For me, the vagus nerve isn't just the gut-brain link. I basically use it for pretty much all of my rheumatoid treatments, my rheumatoid arthritis treatments, because of its interplay with inflammation. In terms of a set protocol, what do? I very much do what Dr. Silverman does. I follow the same protocol. I spend a little bit of time on the auricular branch also, but I use the violet laser and the red laser combined, and I basically set it at 10, 12, 10, 12, 10, 12, and just basically run it that way. My treatment times for this usually about 3 minutes. And I'm always going to flash the back of the head as well. And like I said, for me, it's pretty much something I do as a standard into most treatments that I do. But if I'm doing something in rheumatology, it's kind of my go-to for that sort of inflammation.
Great point. No, a lot of literature showing about laser and rheumatoid arthritis. We know the gut, the key to autoimmunity. I know we don't want to go off on a tangent. And the second thing is, you will see the 3-4 of us all have one common thing. We're going to use the laser to help the patient. We may have some different protocols and maybe some different philosophies because of our training, but bottom line is we're all laser owners, laser speakers, and really purport enthusiasm for using the laser. So don't think if one person says one thing and one person says the other, it's an issue.
No.
Well said.
Okay, thanks for that, guys. Jake's reappeared now. I think he's been having a few Wi-Fi issues there, so apologies about that. Jake, did you get to hear any of the question on the video earlier?
I got the question and I missed all the great answers.
Right. Well, we'll send you a video recording with everybody else. But yeah, just talking about obviously the vagus nerve with Dr. Silverman saying that his preference is to actually just use the violet light. I think Dr. Sullivan and Dr. Gair use the red and violet together. Do you have a preference since you started using the red and violet laser?
It's different cases, but yeah. Generally, I'll just go for the ultraviolet because, to be honest, because Dr. Robert Silverman, I was watching one of his webinars a couple of months back, and that protocol made a lot of sense to me. So that's where I went with it. So I probably won't add anything that he hasn't already said. I'm going to assume that people have said that you're not just going to do it on its own. You're going to try and do things like breathing exercises and any other vagal type exercises alongside it. So whenever I'm using the laser, I won't just use it completely on its own. It's very much an adjunctive to anything else I'm doing. Often at the start of treatment, so that the patient has more energy, so that when I do whatever else it might be, they're in a better state to receive that.
Yeah, exactly. I think we all use it as an adjunct therapy. Gents, have you got anything else to add before I move on to the next one?
No, I'm good to go.
Okay.
All good.
Next one is from Martin Anderson, who's also an EVRL owner from Morley Chiropractic Clinic. So for our American audience, is in Yorkshire, which is in the north of England. So we'll just click on Martin now.
Hi, good afternoon to the Laser Brain Trust. I've had the good fortune to meet 2 out of the 4 of you, and I would hope certainly to meet Jake and Dr. Gair at some point. My question is this. I've had a patient that I've treated mechanically for quite a while who was recently diagnosed with cerebellar ataxia. On further investigations, it transpires that he's got a mitochondrial disease. Now, I was wondering what laser protocols that I might be able to utilize to slow down the degenerative process. It's a genetic condition. There's not a solution here other than to maybe just slow down and improve the quality of life. So I was hoping to pose that question to the 4 laser horsemen of the apocalypse, and I would value any input from you and any advice or direction on where to start. I have some ideas, but I am fairly new to this laser therapy, and I would always value somebody with great expertise. So if I could pose that to you, I'd be most grateful.
There's a first one, gents, the 4 experts or the 4 horsemen of the apocalypse. So I'm sure you quite like that tag. Okay, should we start with, again, as we did last time, with Dr. Rob Silverman, please?
Sure. I thought it was a great question. I took some notes. Cerebellar ataxia, obviously damage to the brain, causing an inability for balance, gait, extremity, and eye movement. Once again, and I think all my cadre here will agree that if there's one area of the body that the laser works best, it's the brain, because one of the byproducts of this energy transfer, this photonic energy, is mitochondrial function, brain being the #1 mitochondrial area. So he should, and I'll let some of them give their brain protocols for that. Number 2, Dr. Sullivan has, without question, discussed the concept of imbuing the mitochondria with energy. So if he didn't go into detail, mitochondrial disease, the byproduct of using laser in a specific area is to increase the mitochondria. So it's ATP oxygenation neurotransmission. And the beauty of the laser isn't just ATP efficient production, it's decreasing the side effect, which is free radicals. So for me, I would do all my brain treatments. I would have him move, and I would definitely using in different mitochondrial areas. I think he's on the right track, and I did meet him, and I remember us having the conversation about the brain, and it's a great question for all of us, not just about the brain, but red light or red and violet light. So I just set it up. I was a point guard, guys.
Thanks, Kirk.
Okay, sure. So my protocols on the brain are pretty simple. Again, I go back to some of the stuff I learned from Dr. Karazian is whatever they're weak at, we have them do that while the laser's applied. So that makes it a very simple type of thing, and see how they did with it, see were there positive changes afterwards. So if you're telling me you got some cerebellar ataxia, well, I might do something as simple as having them walk with their eyes closed if they can while I have the laser on the brain, or have them do some balance exercises like a standing Romberg with the feet together, eyes open and then eyes closed, and then in the heel to toe position, maybe do some finger to nose, anything that we can do that we would normally do, say as a diagnostic test, we can also do that therapeutically while the laser is applied. With these, a lot of times I'll either put them on a vibration plate while I play the laser transcranially, or I'll use the percussor, the little tool that we have. I don't know if you guys have that over there in the UK yet, but we'll use the percussor on there to stimulate the vibratory pathways. Is one of the things we like to do. I like to use, in these cases, a combination of the EVRL when possible, because a lot of times we look at what can trigger or make neurodegeneration progress faster, and that's going to be if there's any kind of underlying infections. So I like the antimicrobial effect of the violet wavelength on there, so we can make sure that that's not a cofactor for making this person deteriorate more rapidly. Especially, I would add in Dr. Silverman's vagus nerve protocol on there, so we're making sure that no bugs are crawling up from the vagus up to the brain, so we can try to get that patient in the most optimal situation possible. And then I like to do with these ones like laser shower. You know, I like to use the FX since there's 3 rotating heads, but if you don't have that, at least putting your PL Touch in a stand so you can just kind of saturate the area to try to generate as much ATP as possible. That's what I would do in this one.
Okay, Rob Sullivan.
For me, this is quite interesting because a lot of the time when we look at mitochondrial disease, it encompasses so much. It's going to basically affect everything from fatigue to weakness. We can even get something called metabolic stroke. We can get seizures, we can get arrhythmias, we can get all sorts of things as a result of that. And really it comes down to lack of the body's ability to cannibalize its own inherent energy. And I think when it comes to the laser, especially the violet red, we very much see this electromagnetic transfer of energy, which is really important because it's a very gentle way of stimulating the mitochondria into action. I think in terms of application for this, even though I'm not a chiropractor, I would tend to always use coordinated movements and then staggered movements and then more coordinated movements and staggered movements, and I look for the changes between the two. The other thing I tend to do with this too is a little bit of muscle testing in terms of weakness and fatigue to see if we can get a balance. So I'd always get a baseline first, and then when I get the baseline, see how we are at the end of that and then progress that at each treatment. In terms of, I think you were asking in terms of protocols for it, really with this is something that this is going to be driven by the patient. This is going to be something that's patient-centered, and depending on the response the patient gets, depends on where you focus and what you do next. I don't know if the guys there have frequencies that they favor for this, but I tend to go with frequencies very close to alpha resting states within the brain in order to sort of try to create that balance. So I'd be hitting it with 817, 921. I think Kirk mentioned something about that in a recent webinar there as well. But that's my thing. Jake, how about you?
So I find that really interesting. So mitochondrial disease is the nightmare situation, really, isn't it? You know, if you haven't got energy, it's almost game over. You can't. Your treatment is limited, and the poor patient is so restricted in what they can do. For me, I always think of it in terms of you've got passive and active. So if it's passive, they're just having to process sensory input in, and if it's active, they're having to create that movement and then process the sensory movement that came out of that. So if we have someone with mitochondrial disease, I want to be starting with really passive stuff. So Kirk already mentioned using things like vibration. In terms of doing movements, I would be doing those complex, you know, figures of 8, but all passively at that, you know, to give Martin something to start with. I would start with passive. It's probably bilateral, right? It's probably global cerebellum. It's not right or left. So I do passive range of motion. I do passive mobilization for the neck, vibration, all that kind of stuff. And this is a question back to Kirk, because I'm really interested in how he does it. Is I would tend to do laser and then do a few passive inputs and then maybe do another laser burst again, but for very short periods. When you were doing things like tandem stance and maybe tandem gait and things like that, are you having the laser on? What's kind of time and frequency for that?
Yeah, I do the laser simultaneously while I'm stimulating. If I'm doing that, or if I'm doing, let's say, eye movements or eye stimulation, I like to have it on there at the same time, so that way while that nerve pathway is activated, I've also got the laser energy on there at the same time. And then what I do is, it depends on that patient on what they can tolerate. And so, you know, you have some people that are very kind of fragile to where they can only tolerate maybe say a few seconds and maybe only 1 or 2 little kind of exercises on the day. I always tell the patients, hey, if you feel a little off or a little wonky or anything different, let me know, and we're going to stop for today. And then you'll come back in tomorrow and let's see if we're building your endurance. So as Dr. Sullivan said, it's going to be customized to that patient of what they can do as far as for the time on it. And same thing while they're balancing. Let's say I have the patient close their eyes in the Rombert's position, they start to wobble. Well, I'll get the laser on there and I look for them to improve, but as soon as they start to, you know, not improve, to have more trouble, then we stop. Then that's the time, that's what their endurance was for that day. We'll note the amount of time. Hey, you're able to do 20 seconds standing there today. Next time you come in, let's see if we can get you to go a little longer. That's the way I do it.
Yeah, that's great. That's very interesting. That sounds great. The only other thing I'd add for Martin is, if you're wanting to transition from that passive to active phase, getting the patient just to visualize what that movement's going to feel like. Yeah. Still activating the exact same brain pathways. It just doesn't, you don't get the movement. So he's going to save, the patient's going to save a little bit of energy, which you can still build that neuroplasticity, but without hopefully wiping them out. That's great, Kirk. Thanks very much. I'm going to just
you know, great idea with the passive, but I'm going to piggyback on what all the gentlemen said, in that the laser's actually pulsed. And we found that pulse is extremely effective to get short bursts of energy in it. You may not notice it with the light because one light is pulsing and the other one looks continuous. And it actually, both are pulsing. It just looks continuous because it's over 30 frequencies. It's hitting the skin so quick, our eyes can't pick it up. So pulsing, I'm talking specifically of the laser, is a great, unique feature. In addition, like Kirk had said, that circle, you're turning the muscle on and off. You're turning the muscle on and off, and you're also covering more surface area. So one of the biggest things, these guys are giving you the greatest protocols. I wrote down what Dr. Jake said, but bottom line is the laser set up for success, and everything that we're sharing and they're sharing is giving you just that inherent advantage, making it more doctors. But don't forget that the laser is the gun. All you got to do is fire it.
Absolutely. Well said. Well said.
Yeah, thanks for that, guys. I think the whole point of this and why we set it up was everybody has their own ways. And my father always taught me when I was younger to get little bits of information from anybody who knew anything and then piece it together and adapt your own approach. And, I think you all are in agreement over a lot of things, but I think we'd leave it to the individuals how they want to introduce it into their practice. So yeah, thanks for that, guys. Right, next one is Julia Waring, who is a PL Touch owner. She has a clinic in Lichfield, so that is sort of in the middle of England near Birmingham for my my American guests.
We own maps.
Hello, my name is Julia Waring. I bought a PL Touch laser last November 2019 after attending a talk by Robert Sullivan at the British Chiropractic Association conference. I have two questions for you. Question one is, I have an interest in functional neurology, and I was excited to hear how the low-level laser therapy could enhance brain function, particularly for conditions such as Parkinson's disease. Do you have a reproducible or objective protocol for measuring potential improved brain function in your patients, apart from the patient just saying they feel better? My second question is, are you able to use the laser therapy on patients suffering from osteoporotic fractures? And if so, how effective is it in improving healing and reducing pain? Also, what settings would you use? As yet, I haven't actually programmed in my own settings. I'm just using the settings that are on the machine, such as universal, post-op, nerve root, etc. Thank you.
Yeah, it's a great question from Julia there. Dr. Rob, do you want to get things started?
Yeah, I'm going to touch on the Parkinson's, and I know a couple of guys they're already salivating over that, but obviously she's got the PL Touch, she's got the red light brain protocol. Second, let's not forget 50% of the symptomology to Parkinson's is in the gut. New article that just came out. We can laser for the gut. If you have the PL Touch, you have the red light, really going to help with wound healing. It's also going to help changing it from anaerobic to aerobic environment, which is going to kill a lot of the bacteria. In addition to that, she asked about symptomologies. Well, there is no true test for Parkinson's. We all know that. However, a lot of symptoms, tremor, slowness of movement, rigidity, and posture. So you can use that as a standard laser and do what you call your before and after. I never ask the patient if they're feeling better, because it puts the patient in a position as a little practice management. Oh, well, the pain went away, so that means I can go away. Oh, the pain didn't go away, so that means it didn't go away, so I'm going to go away. So I try and use what they say to hit my checklist. So there are those symptoms. Interesting, they are without question reproducible. 50% of my practice is gut to brain, so I'm seeing that brain neurodegenerative disease. And I know these guys are going to jump all over that. So as far as the osteoporotic fracture, I should know because I have multiple family members that have it. So without question, you can use it. It's without question also quite effective. The settings for bone. So I do 8 minutes for bone is 2045, 30594, 8687. Osteoporosis, the setting is 20, 600, 660, 1600. So you would do one and then the other. So I'm not a huge frequency guy, but I think it's a great starting point to go. I do believe that you start with a frequency, but you need the variety to ensure that the body doesn't adapt. You want it always trying to adapt to some new stimuli. Why are all the guys doing the brain doing stimuli? Because stimuli is critical. So I think, Kirk, you're up, man.
All right, thank you for that. Great answer, perfect answer. So not too much to add, but here's what I would do for her for outcomes. You can do it as simple as film the patient walking in, do your laser, film them walking out. Because what I see with my Parkinson's patients is a lot of times they'll come in really shuffling. We'll do the laser and they can move out of the office a lot quicker. You can see quite a difference. And we make sure to point that out to the patient. Hey, listen, do you hear how the feet aren't dragging as much? The steps are a little bigger. Their movement's a little better. So it's really a matter of looking at what's the function that they're losing. Is it is it that slowness of movement? Is it things even with their cognitive function, with speech? And so we'll compare that pre and post as far as what has improved and what's still problematic. We know Erchonia did a pilot study back in 2009 on Parkinson's, and they found that patients had improvements with less freezing, faster gait. So they used outcomes assessments on there that she can look that up on PubMed too to get an idea. When it comes to the fractures, I agree with Dr. Silverman. I use those same frequencies as well. I also, another one that if you want to look at what's been in some current research, they found that the frequency of 2 hertz was also really beneficial for bone healing. So I mixed that in with the settings that he said, because like Dr. Rob said, you got to get some variety in there. So it's just like with exercise, you keep doing the same workout, you can get accustomed to it and it's not as effective. I like to mix in some different frequencies as well. Okay, so
thanks,
Dr. Rob.
Sure. Dr. Sullivan?
I don't really have too much to add other than the fact that what I tend to do is record what people are doing when they come in. I tend to record through the treatments, and I tend to basically then let them see that afterwards. The kind of patients I tend to work with this would be people who would have coordination issues, where simple tasks like drinking a glass of water and stuff like that is very, very difficult to do. So we would basically start the laser at the same time as we're trying to get them to drink the water, and we get very quick, very positive changes then, because you're not just you're reinforcing a function. In terms of fractures and stuff like that, I mean, from reconstructive orthopedic podiatry, loads of times I would work with osteofractures and stuff like that. And what I tend to do with this is I tend to I have random frequencies for this, and I tend to rotate. So I use 3 different sets of frequencies in one treatment, and then the next time I see the patient, I'm going to use completely different frequencies again. Pretty much that's it. I have nothing more to add than the guys have said already. Jake, have you more to feed into that?
Yeah, so I find Parkinson's is hard. It's a tough one, right? So for Julia, in terms of what she's actually going to do with the laser, I think the stuff she probably would have figured out herself is that she wants to go for the basal ganglia. But as Dr. Silverman's already mentioned, it's not just the basal, it's not just in the basal ganglia, right? We know that Parkinson's is going to hit the gut. It's going to use sense of smell. We know that depression is one of the biggest symptoms of Parkinson's. So if I'm doing it, I won't just go for basal ganglia. I want to go over the frontal cortex to try and hit smell, because they lose sense of smell and taste, depression, and all that kind of stuff. And then you've got all your autonomics as well, right? So they're often going to get those horrible stenos, dark blue, clammy hands and feet. I think one way to describe Parkinson's is that patients, how when they start that forward shuffling gait and they won't stop until they hit the wall, I think that also happens with everything else. They can't change direction of thought or emotion. And I often find it's hard when you try and point out differences of like, hey, look, you're walking better, because they're often focused on how bad they're feeling. They don't have the ability to change that and be like, oh, look, I can see it. So that's one of the cases where I'll always say, bring your partner in or a friend or something, and then they're my, proof of concept that they can say to the patient, oh my God, your tremor's gone. And they're like, oh, is it? Oh, great. But yeah, it's a tough one, but I think everything these guys have said is great.
I think one of the important things there as well is, and you said it there, Jake, support process, because these people usually have somebody who cares for them and who's with them. And I think sometimes in order to combat that sort of descending cycle into despair, if we can have somebody who's actually visually able to say, well, look, this is, because a lot of the time they come into us and they say, well, look, we're the medics, we're the doctors, of course we're going to say it got better. So I think really when you've got that objective opinion, it actually helps, because treatment is only partly what we do. It's also partly the environment that they go back into, the people that they live with. That's also part of the treatment. And it's a case of being able to manage that also.
And I think sometimes we're more excited than the patients, right? So you see them walking better or like an arm swing come back and we're like, whoa, that's amazing. It's the best thing ever. And the patient's like, yeah.
Shit, what?
Yeah. It's like a few other people in the room and get a bit more energy and everyone starts feeling a bit better, then you've got that lift.
Yeah. Yeah, and I think a key thing there too is managing their expectations too. Making sure that they understand, as you mentioned earlier, Jake, that it's a tough one. It's a neurodegenerative process. So it's not like we're going to cure them. We're going to try to get some function back and try to prevent them from progressing as well. And I agree with you, bringing in the spouse or a family member is very important to reinforce that, because as you said, oftentimes the spouse or family member notices the things and understands the condition better than that patient does themselves.
Yeah, fantastic answers, guys. Yeah, you guys have got me drooling actually with the answers here. I think this is a long way. It's going towards being the best webinar that we've done so far. I think it's a great idea. Okay, we've got Julia's questions, and we'll obviously forward the video recording to you, Julia. Next one, if I hopefully pronounce her name right, Lucy Schleibach, and Lucy is an EVRL owner. She came actually to Dr. Rob Silverman's seminar he did in London on the 30th of November last year, and yeah, within a month she bought an EVRL laser. Yeah, she's from West Moseley in the UK, which I'm not going to actually tell you exactly where that is. I'm not sure myself, but I will play her video now.
Good afternoon, guys. Thank you for taking the time to put on all these webinars. I've learned a lot from you all over the last few weeks. I'm now back at work, and yesterday I saw a patient with Parkinson's. I've been using the EVRL to treat his chronic neck pain, but I'd love to be able to do something for his Parkinson's too. So I'd be grateful if you could share your expertise and any protocols that you have for treating Parkinson's with a laser. Thanks.
I think we covered that a lot, guys, didn't we, on the last question? But have you got anything else to add, Rob Silverman, please?
It's so funny about the Parkinson's and something that Kirk said about it's a degenerative disease. So I had an ALS patient come in. I've been treating him for 4 weeks, and he says he's a little better. His balance is better. And he says, well, how much better do you think I'm going to get? And I'm like, it's a degenerative disease. So first, you're not getting worse. You are getting better. For me, that's the field goal. That's a touchdown. That's the home run. So again, one thing you have to understand with the laser, and it's not necessarily scientific, is you have to manage expectations. They don't feel the laser. So our explanation, and I think everybody should at some point share an explanation of what's going on, what they're getting, is critical, because you control the ball, if you will. You have that encounter. If you just put it on somebody and their arm goes up, they think that's supposed to happen. How many times have you guys done something, forgot to say, here's what's going on, and they go, oh, wow, that's great, like that's normal. If you only saw Michael Jordan play basketball, you would think that's normal. You have to explain that there's a bar, and then there's other professionals, and there's Michael Jordan, the Bruce Lee, the etc. So not so much about the condition, because I think you said asked and answered, and they all gave great answers. I think it's more how you handle the patient within the use of the laser, because for me, I can't practice without the laser, but I have to explain what I'm doing.
Yeah, well said. I agree on there. I think one thing I do kind of goes along with what Jake said in a lot of these patients, as you talked about doing with smell. We'll do that. A lot of times with these Parkinson's patients, I'll do general stimulate each of the cranial nerves basically. So we'll go through and see what gives them some improvement. So we'll have them sniff some essential oils. We'll even use that as a marker too, going back to a functional perspective, to where there's the peanut butter sniff test, you know, where you should be able to smell peanut butter from 12 inches away, and you compare in each nostril, and the closer you have to get it, it's more of a sign of that neurodegenerative process. Is we'll have them sniff the peanut butter while we have the laser on there, and a lot of times you can see all of a sudden they can improve it, or people who have no sense of it start to have it come back. So we'll do that. I'll do some cardinal fields of gaze, we'll do some pen light stimulation, some ear stimulation, etc. We'll have them do some tongue movements, facial movements, just whatever we can to see if we can get an improvement in there. That's one of the things I'll layer on there with that. And I agree with you, Dr. Rob, that the way you explain it sets the patient up for understanding what's going on there, so they don't, you know, have any misconceptions about what laser's doing and what it's not doing. It's important for them to understand what are the pathways that it's affecting the mitochondria, affecting brain-derived neurotrophic factor, you know, creating new synapses, decreasing inflammation, stimulating nitric oxide for blood flow. We'll break that down in a really simple grade school type of explanation for them, which I'm sure we can go over that later.
Yep, Rob Sullivan.
I basically, the only thing I'm really going to add is it's really a management process. Like anything that I do, I'm not looking for cure, I'm not looking for miracles, I'm just looking to get the client into a management process. I tend, when I'm working with Parkinson's patients, to pick one thing, and if it's smell, then I'm going to work with smell. If it's vision or thought, I'm going to work with vision or thought. But having said that, I think the important thing to remember too, from our point of view, is that the laser has a global effect. It doesn't matter if I pick just one thing. I'm actually treating many things at the same time, just as a result of using the laser, because of that electromagnetic energy transfer.
Good answer, Rob. Jake?
The only thing, nothing to add on Parkinson's in terms of protocol for it, but just for Lucy herself, she got to remember that part of that Parkinson's is that flexed posture, right? And that patient tends to be stuck in that position, which is why I often see impingement syndrome is one of the first pain syndromes they're going to come with. But neck pain is pretty common too, right? Because they're always flexed forward. There's a lot of stress on the neck. So something else you could do with the laser is just go to the back of the neck and look at those greater occipital nerves, lesser occipital nerves, and things like that. And remember, there's probably some pain sensitization going on there, which is why this patient has come to in the first place, because he's always compressing those little nerves. So apart from the brain-based stuff, she probably wants to go and have a look at the neck with the laser alongside her other chiropractic stuff that I'm sure she's very good at.
Great, thanks for that, Jake. Right, that was the end of the videos that we were sent. I'm hoping that a few of you on the call, even if you didn't have pre-prepared questions before you came on, maybe some of the items that the guys have discussed here triggers something off in your thought process, and you'd like to wave your hand and ask us. This again is from Martin Anderson, who was on earlier from Morley Chiropractic. I'm getting plenty of patients of late who are struggling with chronic pain, sensitization, chronic fatigue, fibromyalgia, overactive immunity systems, and a bewildering myriad of musculoskeletal pains. The whole system and homeostasis is out of balance. I'm using musculoskeletal protocols with nutritional support and breathing exercises. What global approach could I try with the laser? And you guys can read the last bits. If you want to start with that, Dr. Rob Silverman, please.
Absolutely. So, gentlemen, let's look at this. We're all talking about a patient, and as all the doctors know, we talk about cases just like we are now, and we're all getting better. So, struggling with chronic pain, chronic fatigue, fibromyalgia, overactivation immune system, a myriad of musculoskeletal pain. So, to me, it says the gut's got to be involved. And who would have thought up to a couple of years ago that we would have added a gut protocol with the laser? But now we're doing it. So for me, again, I know Kirk and Jake are brain brace. Dr. Sullivan is that reconstructive orthopedic podiatrist. I'm kind of gut based. I believe it's the epicenter of everything. And I think that everybody all agrees that gut health is critical. Gut is a great part, is a great starting point. Having said all that, you can use the PL Touch, and you can also use the EVRL. Every laser is versatile enough to help. Now, this person, his doc's on the right track. He's got the EVRL, he's got the thyroid, he's got the brain, he's got the gut, he's got the vagus, he's got the adrenals. So when people say, wow, I'm doing the protocol, the real question is, well, how long are you doing it for? Are you doing it for 30 seconds? Or are you doing it for 3 hours? So I think like we all agree that gut's a great starting point, and he's actually doing everything great. So the two things I think he's looking for, or we need to tone up for him, is how long would we apply it to the gut, and the system, like what system? So we all teach, right? Everybody goes, where do I start? What do I do? So for me, I look at the gut with that EVRL. I'm going to use the violet light on the gut. So I'm going to start with that because I'm going to try and kill the bacteria. I'm going to do that for about 3 minutes. I'm then going to switch to the red and violet laser. I'm going to do that for 5 minutes, and then I'm going to upregulate the vagus nerve. For me, it's the system that I start, what I adhere to after doing all the different things that we do in assessment. I'm looking at systems. I'm letting those symptoms lead me to the systems to try and get what we call that root cause resolution. So whatever system, organ is out, that's what I'm going for. As Yanda said, he who treats the side of pain is lost. Let's not be myopic. So I hope everybody agrees that the gut is a player. And let's share like how long. So that's, hey, I'm doing this. And then I'm like, well, I did the same thing. And they're like, well, how'd you get it? Well, my laser is different than your laser. That's a joke.
Right.
So hopefully I set you up under the basket, Kirk.
You definitely did. You got a nice lob. I'm gonna do a 360-degree dunk on that now.
I love it, like Michael.
No, exactly. No, I totally agree with you there. And yeah, I try to look at the whole system as well too, especially when you look at the gut and the brain. You've got the bidirectional pathway there. And when we look at the loops of physiology, it's very important because everybody can get pigeonholed into just everything becomes just whatever their specialty is. But you got to remember to look at the patient, and especially one like this where there's global things going on. I have a lot of these patients come in because of me appearing in Dr. Isabella Wentz's Thyroid Secret documentary and in her New York Times bestseller Hashimoto's Protocol. I get a lot of them who come in just like this. So what I do is I'll do the same approach like Dr. Rob said right now. The thing that I do is then I look at how much time I do it based on that patient. Like I might start off with the same kind of parameters and then maybe add in a brain protocol that's 5 minutes on top of it. And then I'll check with the patient, hey, how'd you do with that? And then on the next one, we might increase that by 1 or 2 minutes to see if we can get a better improvement. So now we've customized the time for that patient to where we'll go up. Like I've had one particular patient who came in, we found her sweet spot is a total treatment time of 12 minutes to where I actually will stack multiple lasers in once. So I'll have my FX going on her transcranially while I've got the EVRL over the gut, and then I've got another one over the adrenals at the same time and an accelerate over the thyroid. So I'm doing multiple protocols at once if you have all of these lasers. And I found that a total treatment time for her of 12 minutes is perfect. If I go longer, if I go to 15, she gets no extra benefits. But if I go shorter, if I'm at like 8 minutes, it's not the same. 12 minutes for her is the sweet spot. So that's in her chart that I'm doing 12 minutes with her. It's customized to what's going on with that particular patient. So Dr. Sullivan, on to you.
I suppose as the non-chiropractor, I suppose my approach is a wee bit different. I kind of look at this, I suppose, more globally than I would have looked at a lot of things. I think the first thing I look at with this is food is medicine. And the second thing then that falls into line when I look at food as medicine is we got ourselves into this situation. So all of this stuff that's going wrong, we managed to get ourselves there. So what I try to do with patients like this is I try to look at systematic rehabilitation. Like we spend a lot of time rehabbing muscles and stuff like that. What about rehabbing systems? So I kind of look at this in terms of systematic rehabilitation and re-education of the body itself. For me, the important areas which I very much learned from you guys over the years for this would be in my protocol would be the vagus nerve. Primarily important because we're going back to food is medicine. We ate ourselves into this situation. We're going to have to do quite a lot of things to get ourselves out. I would then tend to sort of work towards the frontal lobe and very much the motor cortex in terms of getting things to get back into sync, getting things working a little bit more normally, especially when we look at the way the immune system can actually get overactive. And I think an important part of that too, which we're also getting at the same time with the vagus nerve, is the brain stem, because we want to try and get everything back into that relaxed state. Because if we've got stuff going on with this gut-brain axis, we've got our whole body into this hypersensitive state. And I think one of the best ways of bringing that down is, like Rob said earlier, is hit the vagus nerve, get the brainstem doing what it was designed to do, and get ourselves into that nice, soft, gentle place. Then we can start to rehab the body systems. In terms of time index, I tend to spend between 10 and 15 minutes with patients on this. And a bit like Kirk, what I do here is I have an old Zerona. And I get the Zerona going and spread out. I have them lying down, and I'm basically conditioning the whole system. And then at the same time, I'm using the red violet, and I'm just tracing the vagus nerve. And that's pretty much my thing. Does it work? Patients are happy. Am I happy?
No.
Yeah.
Yeah.
Jake.
You're Irish. You're meant to always be happy, right?
It's the whiskey, boy.
Yeah, that was all great. From brain gut access and thyroid, I've got nothing better that I can say anything to add any value to that. The only thing I would say is when you're looking at pain sensitization, we often use that word chronic. I mean, in its truest sense, to mean time. So it's just the patient's had that pain for a long period of time. The severity of the injury. So I want to know more about what happened. So is it like a whiplash? What happened that caused that pain in the first place? So if a patient's had a severe whiplash, the severity of that pain in the first few hours is going to dictate if this is going to become a chronic problem or not. Or has this been a small injury that just lingered for such a long time that bombardment into the dorsal horn just slowly ramped up and became sensitive? So when she's got that widespread pain, Dr. Silverman's spot on, it's everywhere. But there's some research that suggests if you can find the origin and significantly reduce pain, so not like a little bit, like we're talking really, I don't know, corticosteroid injection or whatever it is, really ramp down that pain, or maybe using laser or manipulation or whatever skills you've got. A lot of that other secondary pain, when he's talking about a myriad of musculoskeletal pains, a lot of that will go. And, again, within hours or days, and then suddenly you'll get left with someone who's got a severe neck pain or a severe back pain, and suddenly treatment becomes less bewildering and like, where the hell do I start with this? And suddenly you've got a target area. But that's easier said than done. But yeah, that is a possibility.
Hey, Simon, I'm trying to be that loquacious New Yorker. I do apologize, but I thought that Dr. Kirk did a great job on mentioning the multiple lasers. So you're not limited to using one. Now, again, I think everybody other than Jake right now has like 3, 4, 5 different lasers. So what Kirk was saying was great. You could laser someone's brain and laser someone's gut at the same time. You can laser someone's brain and laser someone's extremity and musculoskeletal. And that's ultimately where you want to be. You can have a point and shoot, and you can also have movement. So the idea of the multiple laser is what we do. We have an advanced seminar. Kirk and I are both involved in that. So that's a great point. Dr. Sullivan also brought the point about lifestyle. So, in that, I can't speak to what he did 5 or 10 years ago, but when you start adding lifestyle, nutrition, they're profit centers. Yes, they're means of helping the patient. Yes, they're synergistic. So laser, it may be your backbone of revolutionizing, i.e. transforming how you practice. And Dr. Sullivan used a really cool thing. He said time index. And I think you should let the panel talk about that, because we always get how long. Well, I'll throw it out. So for instance, if you're upregulating, 5 to 10 seconds. If you're in the room, again, in a chiropractic setting, Dr. Sullivan will speak to the medical setting, maybe a treatment's 3 to 5 minutes. If you're point and shooting like an FX, it's 10 to 20 minutes where you're leaving. So a lot of people ask, the point is it does not slow you down in the chiropractic genre, and the outcomes are better. So it's time, and you don't mind if I interject and let them answer that, because I got a DM from somebody listening on that.
Yeah, I agree with you on the time. Like you said there, Dr. Rob, is let's say if I'm doing upregulation, or what I've kind of coined in my office, I call it recalibration, because the patients really understand that term, that I'm recalibrating their nervous system. It literally takes a few seconds to activate a muscle and turn it on, and then I'll do the same parameters. My average treatment time, if I'm face to face with someone, is going to be somewhere between 5 to 7 minutes. You know, and then I can set them up in another room and have the lasers going. That's one of the great benefits of having multiple lasers. I had one laser for the first 4 years that I practiced, but then I got bogged down because I had a lot of people who wanted to come in. So when I upgraded and got the base station, where I had 3 lasers at once, then I could have, say, a fracture protocol going on in one room. I could have someone getting a passive muscle protocol in another one, and I could be actively doing my upregulation recalibration protocols in another one on there. So that works quite well. And then, as Dr. Sullivan said there, with the Zerona, I have found that a lot of these patients like this, with these autoimmune kind of conditions like fibromyalgia, a lot of times there's an underlying Hashimoto's hypothyroid on there. We get them on the Zerona and couple that with, say, like a ketogenic type of a diet, and eliminate the common autoimmune trigger foods of gluten, dairy, corn, and soy, and we see some amazing changes on there, especially as now that fat's being liberated from the Zerona and being utilized and burned up as fuel. I have a lot of them who now come in, you know, once a week for several months, just because they feel so much better with the laser. Like, they're like, I don't even care about the fat loss anymore. I just love how good I feel. And I think when you stack that, like Dr. Silverman says, with the nutritional approaches, the lifestyle approaches, it's all kind of feeds on each other, and you start to see people that will stick to a nutritional protocol, a plan that maybe they wouldn't have stuck to before, when they're not seeing these kind of amazing results as they do now that they're stacking lasers with it.
I very much agree with Kurt in terms of this. I think time index for me, because I'm medically based, I think my time indexes have to be different, because we all know that everything we're doing, it literally only takes sometimes seconds, at most minutes. And you know, the optical window for the laser is quite small, and we don't need to do so much for so long. And really, is there a benefit for doing it longer? There's a benefit in the mind of the patient, and sometimes we have to work to the mind of the patient. So they're coming into my consulting room, they're used to seeing me either as somebody they see before surgery, somebody they see after surgery. Now they're seeing somebody that is telling them you don't need to have surgery. But when I'm dealing with a lot of these issues like complex regional pain syndrome, immune issues, musculoskeletal issues, fibromyalgia, rheumatoid arthritis, I very much tend to basically use 2 lasers at the same time. I tend to use the Zerona, and I tend to use the EVRL at the same time. The reason I would sort of go 10 to 15 minutes is my patients are paying me for a block of time, and they expect to have some sort of activity or something to fill that block of time. So that's why I would use that. Now, from a chiropractic point of view, if I was doing it as a chiropractor, then I know I don't need to do that, because I've got other things that I can do. But I'm very much using this and suggesting how you can use this as a standalone discipline, if you like, that you can put into your existing practice. So something that you can add to that. And I think really it works very much differently for everybody, really. But I think it's a case of bringing the skills that you have to what you know, and sort of developing that into your laser practice.
Jake, have you anything to add?
No, I found that really helpful.
Hey, Jake, again, Simon hates me. I have a question for you, since, and I'm not trying to put you on the spot, don't worry. I wasn't a boxer or a wrestler. I played basketball. We talked about that. For you, you're the newest to laser, and you mean you've got all these great credentials, and you're killing it, and you're doing a great job, and it's really impressive. I'm compelled, because the more chiros that come into the field and do things like that, it's better for me, because as a chiropractor, the thing we always hear is, well, I went to a chiro, I had a bad experience, and then go to another one for 10 years. So I know that you're changing that. Now, my question to you is, what has that laser done for you? Because that's what people always ask us, and Kirk tells you right away. He and I are, you know, we're very American, West and East, and it's like, hey, how are you? And you know, my mother's maiden name is this. Yeah. So we were curious, like, what has it done for you? We want to get that out of you.
Yeah, it's really interesting. I think that's definitely an American English difference. Is I think, and me and Simon have talked about this in the past, is that the Brits were a little bit more reserved and we're a little bit more suspicious. So you can hear all these great stories about the laser, but it took me, even when I had one, it took me quite a long time to start almost like getting into it. So you do something with a patient. I mean, Rob Sullivan, I don't know if you remember the first time you came to my practice, and I brought my mother-in-law in. She'd fallen and broken her shoulder. Terrible description, but in her head, she'd broken her shoulder. So let's just leave it like that. She had an impingement syndrome, so she couldn't raise her arm above 90 degrees at all. And I don't want to treat my mother-in-law. That's like a worst-case scenario for me. And Rob came in and did nothing, but just lasered the neck, lasered the shoulder, and just had to do this. And I was sitting in the background, being as skeptical as I could be, and just very slowly, over like 3 minutes, was a full range of motion. And she left the clinic happy, and then rang me later that day, really happy, and was like, "Yeah, I still don't have any shoulder pain. What happened? Like, I know you explained it in the room, but what happened?" She'd also, when I left the clinic, we were in central London, which stinks of diesel and buses, and she was like, "Is it weird that my sense of smell was amazing? Like, I could smell the pollen on the trees, and I could smell all the diesel from the cars." And I was like, "Yeah, that's really weird." But I had the exact same experience after Rob treated me with it. And for me, that was a real eye-opener of like, wow, this thing is not just like a little light on someone's skin, there's something happening. And then probably realistically over the next few months, I started to think, yeah, I'm starting to see things. And I'm not as experienced as you guys, and I'm not as skilled as you guys. But I find that, like, I had a patient who tore a calf muscle playing tennis the other day, and that was fantastic. And I actually strained a glute rock climbing the other day, and I went to bed 8 out of 10, really hurting, yelping to stand up or sit down. Lasered it probably 3 or 4 times during that afternoon. Thought I'd wake up in the morning in agony, and woke up and it gone from maybe an 8 out of 10 to, say, a 2 out of 10. So there's some areas that I find, brain stuff I find really good. I find injured muscles. Those are the ones that I consistently in clinic think, yeah, this is an easy one for me. And then I'm slowly trying to build the protocols and the confidence that you guys have with patients to be able to say, "I'm your man, I've got this." But it's coming. It's coming.
Yeah, thanks, Jay. I think it's just a process. Like, I'm sure all the guys, Rob Silverman, Rob Sullivan, and Kirk Gair would have said to them, to people when they first started out with them. And I think this has been a key part of the lectures that we've been doing, the educational programs. And Rob Sullivan did a great one talking about photobiomodulation and low-level laser therapy, because there's vast differences within that umbrella of each topic. And it was educating your peers and others on what the differences are, and working at a cellular level, we can achieve so much more. And we'll carry on these educational forums, and we want to get the lasers out into all over Europe. We're in Sweden, we're in Norway, we're in Spain, we're in Poland, Russia, quite a few countries. I was a bit deflated when we looked at the Spain market to know that chiropractors weren't actually allowed to use lasers in Spain, but physiotherapists are. Which again, I think this is something that not just us as Erchonia, but us as a group, including you guys, can try to sort of shed some light over these situations and this sort of maybe voodoo type, thought process that people actually have. And I know since I got involved with you guys, it's changed my whole outlook as to what you can actually achieve with the lasers. And I thank you very much for that.
I think, Simon, one of the things that's important there is like this whole thing about photobiomodulation. What we're doing, low-level lasers, non-thermal low-level lasers, it doesn't fit into photobiomodulation as far as I'm concerned, because what we're actually talking about is electromagnetic energy transfer. And I mean, when we get that transfer, that's what happens. So when people start talking about depth of penetration, forget that. That's nonsense. We're talking about electromagnetic transfer. That wave, when it hits you, that wave's going to go all the way through, and it's not going to damage anything. It's just basic delivering energy along that track. So, I mean, when we think about this and what we're all doing, all we're actually doing is we're bringing to the body a vital force. And that vital force that we're bringing to the body with these devices, that's energy. And we all need that energy. And I think really the sooner we can sort of educate and stop people thinking about photobiomodulation, oh, that's non-thermal low-level laser, isn't it? No, it isn't. You know, we have a tool in our hands which is vital for delivering energy to the body in a way which is completely revolutionary, I think.
You know what,
guys?
Dr. Cooke and Dr. Gair, I think we're going to have to give Dr. Sullivan a honorary chiropractic degree, because what he just said is, I saw you go like this. That's chiropractic 101. You have just passed the test.
Yeah.
Getting the energy into the body, whether we release it or put it in, and allowing its own pathways to heal. And photobiomodulation was where we were. Electromagnetic therapy transfer is where we are and where we're going. And it's science-based. And every chiro right now, I know I can't see them, Simon, they're doing burpees and they're jumping up. I saw Jake, who's been like real, I'm taking it easy and I'm cool. He's got some energy right now, but you just said what chiropractors want to hear and what we live for. We want to fix the body naturally through energy means. Sorry, Jake, apologize. You're over it.
I'm going to be really selfish and just steer this in the direction that benefits me. So I'm doing my master's at the moment, and I'm just coming to the end of one project, which was all about looking at low-level laser for carpal tunnel syndrome. And one thing that was really frustrating when you're trying to do your research and you're doing your PubMeds and you've done all your clever like search protocols, is that how much of that actually isn't low-level laser, it's coming under infrared. And when you guys are doing your research and when you're looking at things, are there any search terms that you can use, or is there any way to filter out all the, I don't want to say junk, but all the stuff that I'm not interested in? Or is that because it all seems to be lumped together? So if you look at systematic review, it's all under the same thing. Or is that just how it is?
I haven't found a fast way to do it. I've always had to weed through all the crap too, and the things that are say low-level laser, and then it's actually a class 4, like a 3-watt laser, you know, frying some tissue out there, or it's an LED device calling itself laser. So I've just found, I haven't found a shortcut. It's just painstaking me reading through things, trying to find what's good, what's not good. And just to go back on something that Dr. Sullivan said earlier, when you talk about that, you know, depth of penetration, there's 2 of the studies that I show in my live seminars showing that like an 808 laser versus a 635 laser specifically for a couple conditions. One of them was just to try to stimulate testosterone production, and it showed that even though the 808 laser penetrated far deeper, there was 0 change in the testosterone level versus when you had a 635 nanometer laser, there was a massive change, even though it was only superficial. So as you talked about this energy transfer, it didn't go deep, but it still, you know, affected the target tissues. But I found that by just digging. Yeah, I don't know. You guys have any kind of shortcut? I haven't found one.
Yeah. Why don't we look for anything under 660 nanometers? So go by the wavelength. And let's put it in a nice tight bowl. Simon always likes these quick American, like, pardon my expression, takeaways. It's all about absorption. It's not about penetration.
Mm-hmm.
Yeah. Well, we preach that at a whole range of lasers, and we have to answer so many questions over the years about depth of penetration, and our answers are pretty forthright in return. It's not about that. It's about peak absorption of energy in the mitochondria of the cell. You know, we could create this cascade effect, which is when I think Rob Sullivan said before about treating one area, you can reach multiple areas because of the systemic effect that you can actually create from the laser.
Yeah, I think there's a good analogy on that, as you mentioned this too, is this is one I show in my live seminars. Are you guys familiar with Richard Kuklinski, the Iceman? Have you guys seen this? So Richard Kuklinski, there's a Netflix documentary called The Iceman Cometh. He was a mob hitman who claimed to have killed over 200 people in hits. And his favorite way of doing it was with some cyanide. And he would take them to lunch and he'd spill a little on their wrist while he was wearing gloves, or he'd sprinkle a little in their food or in their drink. And the reason why I mention this is because it would take just a little bit of cyanide on the skin to cause a signaling cascade that would shut down the mitochondria and would cause heart death, where it would cause a cardiac arrest because the electron transport chain was broken down with just a little bit of cyanide. So it's not that the cyanide penetrates to the heart, but it's signaled from here to there. And I teach this to the doctors at my seminars that, hey, it's the yin and yang to the laser. We get a little bit of laser here, but this now has this global effect because of the signaling that's occurred and because of that energy transfer, not because it penetrated from here to the brain or from here to the heart.
Yeah, agree completely. Right, fellas, I know we're on a vigilant time schedule, so I'll move on to the next one. Another one from Andrew Jackson. I think we discussed this quite a bit before, but we can maybe elaborate a little bit further. Vagus nerve stimulation protocol. Is there anything else you guys want to add from the conversation we had previous?
You know what? I'm going to jump on for Kirk. Kirk loves that percussor. So one of the things you can do with the laser and the percussor, and he knows where I'm going with this, is I would percuss the ileocecal valve at the same time of lasering it. By doing so, you're increasing the tone there. And that's one of the big things that the vagus nerve has. It's the migrating motor complex, but it's really that ileocecal valve, which is the flap or the doorway between the small and the large intestine. So that gives you the ability. I know you're doing a webinar in like an hour.
Yeah, exactly.
With the percussor, and also doing the vagus nerve. So that would be, if you will, an advanced move, because you would need 2 items. And that's actually how I do it. I just don't show it because the percussor's in the office and I'm home.
Yeah. So percussor right here. But what I'll use on that one is I like using the flathead on there, and I like to go on a slow type of a tempo on there, and I'll laser over the gut while I'm also lasering over the vagus nerve at the same time.
Do you know what brand that is?
Yeah, that's the Erchonia brand. Yeah, that's the Erchonia percussor. So, you're right there. Yeah, let's go. Yeah, Erchonia percussor. I'll use that one and the adjuster tool. Yeah, like Dr. Silverman said, I'm doing a webinar for Erchonia here in the US, literally in an hour, on the adjuster and the percussor tool. So if you want a replay of that, just let us know. We can send you the replay.
Simon, is there a
adjuster we can't get into Europe or the international markets at the minute? It needs to be remanufactured specific to the power source. One time we used to be able to use converters, but I can see exactly where Erchonia is coming from with regard to, you can't always trust a converter, and we're looking at warranties, we're looking at all sorts. So hopefully sometime in the future we'll be able to get the percussor and adjuster over here.
Yeah.
Cool. Right, guys. Next
I'm writing Christmas present.
Sorry, who was that?
I'm writing a note, Christmas present, next to it.
Yes, definitely. Julia Waring again. How good have you found the lasers to be for endometriosis? I have a patient with a severe case. I tried the laser on her once. She thought it stirred it up a little, so I haven't tried it since. Dr. Rob Sullivan?
It's interesting. Yes, I've got good results with endometriosis. By the way, again, really to piggyback on what Dr. Sullivan said earlier, and Dr. Cooke and Gair, I incorporate nutrition, and there's a nutritional protocol for endometriosis. Again, this is something that we talked about before. Only one treatment. Sometimes the patient gets a little sketchy. Has anyone ever cleaned a pool? It's dirty at the bottom, right? And you clean it. So maybe you do stir it up, but if you stop, what happens? It settles back down, you didn't get anywhere. So I'm not saying that it doesn't stir anything up, but healing is a process. And some of the process will be a change in sensation, a change in feeling. So as long as that patient doesn't say anything that is extremely deleterious, that's how I explain it. How many times have people come in and said, I'm in pain, but now I ache, and they're angry at you? Well, that's the next step, pain to ache. Same thing with the endometriosis. You may be stirring up the dirt from the bottom to get it out of the body.
Yeah, I think that's a great point. I think this goes back to Dr. Rob, as you were talking earlier about what's your script? What do you tell people that the laser is going to do, and what are their expectations? I always, regardless of whatever I'm working on that first day, I always tell them, hey, you might be a little sore, you might feel a little flared up for the next day or two, because we're starting to work on some things. It's like going to the gym. You go to the gym the first day, you do some exercises, which is good for you, but you might feel pretty sore for a day or two. And that's as you're remodeling the body, you're trying to fix it. You may get these different things as these side effects to start off with. It doesn't mean we've made you worse. It's just part of that healing process. And so I try to make sure they understand that, especially with a case like endometriosis. If you're trying to use a laser, that's going to take some time. You're going to try to work on that. You got to do, like Dr. Rob said, the nutritional protocols. A lot of women with endometriosis are also going to have an underlying Hashimoto's going on there as well too. So you got to consider those types of things. But I have seen some benefits, and if you look at what the laser is going to do to decrease inflammation, to stimulate blood flow, all these different positive things that can help it, you can get some benefits. Just make sure manage your expectations. And I'd rather under promise and overproduce the results. And I'd rather tell them, hey, you're probably going to be sore, and have them come back and say, oh, you know what? No, it wasn't. I didn't really feel anything. It wasn't too bad. Because if you lay that out there, then you're ahead of the story. Then when they come back in, they're like, oh yeah, you know what? I was a little flared up like you said I would be. Whereas if you don't say it, then when they come in, then they can be like Dr. Rob said, they can be upset at you, saying like, hey, how come you didn't tell me I might get, you know, my leaves in my pool stirred up here?
Yeah. Yeah, definitely.
Rob? Endometriosis is something that I suppose I kind of wandered into as a result of one of the clinics that we have in Hamburg. And they basically had found that by doing different laser treatments for fat cell management, that people were experiencing changes in this endometrial issue. So from there, we kind of looked at that in terms of what could we practically do. And I think what I do with patients that have this is the first thing we do is I want to know their cycle timings. I want to know their menstrual timings. And what we tend to do is we tend to work around that so that we're not treating a couple of days before we get period and a couple of days afterwards. And the reason for that is because these lasers are going to increase blood flow, increase blood supply. So we don't really want to, personally, I don't really want to upset that too much. So what I have found with this is by treating patients for 3 weeks out of a month, we tend to basically calm this whole thing down, usually between cycles and before they get to their next cycle. And again, with this, what we're targeting, I think all of my practice is geared around two things. It's geared around treating first the dermatome for the area where there's a problem, using movement where possible, and then going to the area where the problem is. So basically, with working with something like this, I tend to basically treat lower T, base S, and into the mid L spine, because that tends to be the areas of interplay in terms of the dermatatic areas from a medical point of view. And then what I would tend to do is I tend to treat over the ovaries around the uterus, that area, and basically again with movement where possible. So I would get the patient to take very, very deep breaths, hold them, blow the breath out, just so that we get some movement there. And what I find in my practice that works very well with this are calmer frequencies, lower frequencies. I tend to use, again, I would either use the FX and the EVRL at the same time, or if the EVRL isn't available, we'll go with the FX and then introduce the EVRL into the next cycle. But it's something that I wouldn't shy away from treating. And like the other guys have said, sometimes we start treating something and everything seems to get worse. My response to that in the early days was put my hands over my head and run. Now, when that happens, it's a case of I think, God, yeah, we're getting there. And it's positive. So again, manage the patient's expectations. It's a counseling role that we have as well as a treatment role. So basically counsel them. But at the same time, I would never say to my patients, oh, you may be in a situation where this will make this happen, and the other thing happen, because I don't know about patients in the rest of the world, but Irish patients are quite suggestible. And I don't want to suggest in a situation that's going to mar the outcome in terms of what I'm seeing and in terms of me interpreting the problem.
Yeah, definitely. Jake?
It's not something I work with, so I've found it very interesting, but I haven't got anything to add to it.
Simon, are you there?
I think that he just texted me and he said that
I'm back now. No, I was sorry guys, I was accidentally on mute, so I was talking away to myself. I was saying we've got around 7 or 8 questions to go, and I know Kirk's got to go off on another Erchonia webinar, so we'll get through these. Another one here from Julia. Can you use the laser as a tool to determine whether someone needs surgery? I have 2 cases of hip pain which have failed to respond to the laser and required surgery. How many treatments would you expect to give with the laser before deciding that the patient actually needs surgery? Dr. Rob?
Can I take this one first?
Yeah, you know what? Why don't you do that? That's a great idea.
Yeah, I mean, surgery, I mean, you're talking to a guy that's gone from 490 ops a year down to about 12, 13. Like, I just do enough surgery now to keep my skills in. And one of the things that I noticed very quickly when I started using the laser is how many joints I'd actually replaced that didn't need to be replaced. Because what had actually gone wrong was the periarticular tissue around the joint and stuff like that. And a lot of the time when we think about when you have to think of is my surgery going to benefit the quality of life? And that's what I would have thought of before. Whereas now, because I have lasers, I basically think, okay, what can I do with this laser now that I have the evidence of what's wrong? So I would look at the evidence, I would look at the scans, I would look at the CTs, MRIs, whatever I had available to me, and I would basically treat according to that. And I think I could safely say probably about 89% of the time, patients that think they need surgery don't need surgery. What they basically need is their systems to work properly. Because the reason we have surgery is because there's a breakdown or a failure in a system. So sometimes it's just a case of bringing those systems back to work. Will the laser fail? Of course it will. I mean, the laser is a tool. It works a lot of the time. It won't work always. It will always bring a change, but that change may not always be enough for what the patient wants. So sometimes do we need to do surgery? In my view, as a surgeon, yes, but do we need to do it as often as we think? No, we don't.
That's a good answer to that. Anybody else have anything to add?
No, I think he mic dropped it. Yeah.
Yeah, no doubt.
So would you, let's say you wanted to start with laser anyway, would you say to a patient, let's trial a 6-week period, and if we're seeing positive changes, then you keep going, and if you haven't seen changes by 6 weeks, then you stop, or what?
See, you guys have an excellent tool there. You're chiropractors, so you know a bloody sight more about this than I do. But one thing I know about lasers is if I have a patient and I want to troubleshoot their system, I'm going to use the acne protocol on the EVRL because I use the violet laser as troubleshooting for the system. Because by systematically going through systems, you can actually find out exactly what's wrong. I mean, violet is an excellent diagnostic tool.
Yeah, true.
Agreed.
Thanks for that, guys. This next question is from Sarah Wilkinson from Neuropathy Works in Bolton, which is in northwest of the UK. Prices for laser therapy. Do you charge extra for laser therapy within your clinic sessions? Also, what do you find works in terms of marketing? Obviously, as she said, it can be a little different from America to Europe. But Dr. Rob Silverman, if you'd like to start with that, please.
So when I started with laser, I went through this whole curve, if you will, and this precipitous increase. What I did was I didn't charge for it, and that was a bit of a mistake. Then I started to charge for it. Then I found out how potent it was and the stellar responses that patient had. And now, I think Kirk's in the same boat as me, we charge for our time. So it's transformed our practice, not just in outcome, but financially. So everybody always thinks when I add a new device, I've got to get new patients. You don't. There's gold in your files. Everybody that you've seen, you need to let them know about it, whether it's social media, whether it's a video, whether you write a flyer, whether you do a constant contact, whatever you do. It's 3 times easier to reenact or reactivate a patient that has seen you than bringing somebody new. They'll bring in their bunch of people, their groups, and before you know it, you now have a laser-based practice with increased outcomes, and you're going to be really busy. So, and when you're busy, you're able to make those financial changes. You're able to make the case changes. Now, I know it's probably different in Europe, but as my friend said, business is business. You give a good service, you position yourself well, things will fall into place. The one thing I will say is, every time my intention was good and I wanted to help people, the money followed after. Every time I said, hey, I want to make more money, the man upstairs said, no way, buddy, you're on that puppet string. It just ain't happening.
Yeah, agreed. And I did the same thing that you did, Rob. I started off, I gave it away for free. What I did though is I picked who were my, she talks about marketing, I picked who were my best patients for the ones with the biggest mouths, you know, who's going to tell everybody. So what I did though, instead of just giving it to free without them knowing about it, I said, hey, listen, I want you to try this new therapy that I have, and I want some feedback from you. Let me know how this works. Normally, I'm going to charge, at that time, this was 2004. I said, normally I would charge $25 for this on top of what I'm going to do chiropractically, but I'm going to give you this for free. And again, this varies what your rules are as far as for free services from state to state or country to country. I said, I want some feedback from you. And so then I got feedback from them. They were blown away, and they started yapping and telling everybody about it, and it started generating the referrals. As Dr. Rob said, as we got busier, we kind of got like Disneyland, to where we actually needed to increase the price to thin things out a little bit. So we found out what could we do to where it kept us, you know, full per day, and charged a reasonable price that helped us, and also wasn't too much for the patients. So now what we do, my minimum laser charge, whether it's 1 minute or 5 minutes, it's going to be $45 minimum. If we're doing longer, like let's say if we're doing the 20-minute low back pain protocol, that could be $100. If we're doing a really complicated neuro kind of a protocol, that one might be $125 because it's time and complexity on there. But when I was doing just my sports stuff, it was a flat $45 fee on top of what other things we were doing. And as far as for the marketing, it's really with the word of mouth. It's generating that wow in the patient. They go out there and they tell other people. And then with social media, what I did was I would get permission from my patients to share their story, like a testimonial on social media, and I would share that, or I'd do an interview with them and share the video on my YouTube channel. And what I did is I didn't make it salesy. I didn't put a call to action like call our office to get blah, blah. I just shared the story. We just shared the story. So it was just, the intention was there of just sharing the information. And then we'd have people contact us and say, hey, you know, I know you're busy, but do you think you can get me in? That's the way it worked for us to create a referral-based practice.
I think for me, it was lasers came into my practice pretty much in the middle of the last recession. And if it wasn't for bringing lasers into my practice at that time, I wouldn't be in practice now. I'd probably be driving a plane or you know, digging in the garden or something. So these lasers basically changed the way I practice. How did I market it? Had no money for marketing. But what I did have is I had 3 patients from hell. And these 3 patients from hell had the biggest mouths that anyone. So I decided to take a risk, because if I treated them and it went wrong, I was stuffed. If I treated them and it went right, I was fine. So fortunately, I'm still here. So obviously it went okay. Am I cheap? Am I expensive? I'm actually the dearest clinician in my area. I have always been the dearest clinician in my area. If anybody around me puts their prices up, I'm going to put my prices up again, because, you know, I'm the most expensive clinician there. Like, we charge 60 euros for a 15-minute session. If it goes beyond that, then we can adjust accordingly. But I'm not a chiropractor, so I'm using laser as a standalone treatment on its own. So we would have the standard diagnosis that we would need. So we would have X-rays, CTs, MRIs, etc. And once we have a diagnosis, we will treat according to that. If we're making the diagnosis ourselves, if we're having an initial consultation, to get to that point, we're looking at 175 euros. So I don't think patients mind the price. I think they do mind if it's cheap, because they have no benefit in it. And we have this thing in Ireland where we say, if you sell it cheap, they'll have no mass on it. If you sell it more expensive, they will. My case in point was, we used to make orthotics. Woman down the street was making the same orthotics as us, and she was charging 375 euros. I was charging 90. When we put our price up to 400, we sold more than she did.
Crazy.
I found that
crazy.
I found that really, really interesting. I think my journey has been exactly as Dr. Silverman and Dr. Gair have described, and I'm in the phase now of educating my existing patients and the patients who I've got a relationship with, explaining to them what the benefits of the laser are. And it definitely, you know, I'm not a practice build, I can't educate people on practice management, but my one tip is be remarkable in the truest sense of the word. People should remark about you to somebody else. And the laser is remarkable because it's completely different to anything they've ever had before. And someone who's maybe failed, so I will see a lot of patients who are referred by other chiropractors where maybe they haven't got the result they're hoping for. And be able to say to a patient, right, the kind of chiropractic part of it works this way, and the laser is completely separate to that. It's going to work in a completely different way, and that's going to give us a real step up. then they go out with a bit more hope. They remark to their partner, and yeah, it's definitely a practice builder.
Yeah, I agree completely. I think also Dr. Gair hit the nail on the head. I think it was back on something like the 14th of April when you did that webinar with Penny, and you talked about how to come out of, you know, this COVID-19 situation. And I remember you saying that you sort of turned your practice recession-proof by introducing these. And you know, it's a process. But you know, we provide all of the support behind the scenes for these sort of things. We have a marketing collateral file. We have the likes of Dr. Gair, Dr. Silverman's webinars that they've done before about how to grow their practice. So you know, there's a lot of support there to give you guys ideas on how to get the best for your practice. Okay, guys, the next one from Sarah again. Do you know of any contraindications at all on treating a neurologically impaired patient with low-level laser therapy? Are there any contraindications with regards to epilepsy, seizure sufferers, for example? Rob Silverman?
I'm going to give that a no. I don't have any contraindications, with that caveat of when you apply the laser to the brain, and I think Dr. Cooke said it, he does it for a short period of time initially, see how they respond. I think everybody's alluded to that. So I'm going to say no, but you don't. So I typically use an FX 635 on the brain for 20 minutes. That's a lot of energy going in there. So you don't want to overstimulate someone in this isolated area or isolated incident. So I would do 30 seconds, see how they are. 60 seconds, see how they are. I would solely titrate up to see how they respond because of their condition. Someone like me or the gentleman on the panel or you, Simon, I would immediately go for the 20-minute session. So again, no, but again, the caveat with caution.
Yeah, I agree 100% there. Whether it's that or if it's a concussed patient, same thing. I want to see what their tolerance is. I don't want to overstimulate them too much. If I do a little bit, that's not bad, but I don't want to crash them out. When it comes to like epilepsy and seizures, I think the only thing you really got to be careful of, since there is a pulsing going on, is, you know, I would keep that away from their eyes. Otherwise, that flashing could potentially trigger you know, a seizure in that, because we know that just any kind of flashing light can trigger someone. Video games can trigger them. So I would probably just keep the laser off towards the back of the head or the top of the head, so they're not actually seeing it there. And I have patients who have epilepsy in my office, and that's what we do with them.
I think I'm the same as well. Like we treat patients with epilepsy, but I kind of use occlusive laser glasses. So I use thermal laser glasses where it occludes all light. And I would basically start off and seeing what their tolerance is and just go to tolerance and then increase that a little bit, as the guys have said. But I mean, for me, it's just a case of we always use the glasses that occlude all the light.
Yeah, I haven't seen any research that says, any research that says there's been any contraindications to anything that I've looked at.
Great.
No, I think the only contraindication would be with high-powered lasers. That's it. You don't use a class 4 on the brain, and you especially don't use a class 4 continuous wave laser on the brain, because that is very problematic. There you can create some damage with those ones. So, but with the Erchonia lasers, you're not going to have any problems.
Yeah, thanks a lot for that. Next question, going back to Lucy. A patient of mine would like to try low-level laser for his shoulder, his left shoulder and right knee pain. He had a pacemaker fitted in 2005 for atrial fibrillation. However, this did not help, and he later went on to have ablation surgery in 2009-2010. He's no longer classed as having atrial fibrillation, but still has a pacemaker present. And he informs me it only works 10% of the time, and the battery will likely run out in 2 years. Is this scenario a complete contraindication for laser therapy, or could I use it just on his knee and not his shoulder? What would you advise? Rob Silverman?
Well, the corporate answer is going to be one of the contraindications is pacemaker, because modalities, you can't, that's one of the pregnancy and pacemaker, you can't add to it. Now, as far as the ablation, clearly both my parents had ablation surgery, so I'm familiar with that. Now, do I know people who have sent the patient to the cardiologist, explain what we've done, and the cardiologist has signed a piece of paper and said it will not cause an issue? Every time I've had the cardiologist said, do not worry about it. However, the corporate position is no, you just get that patient to go to a cardiologist, because the idea that the laser will drain the battery is beyond antiquated. So I think that's the company position. I saw Kirk, I saw Dr. Sullivan, everybody like nodding their head like, yeah, you know, put it on somebody else. That's why we like you, Rob. We can always put it on you. You can get us off the hook.
Yeah, I've done that. I've also had the patient call the company, the manufacturer, and get it from them that there's no problem with it, especially since it's non-thermal. Yeah.
Great, thanks, guys. Lucy, again, chiropractors in the UK have to adhere to strict advertising standards guidelines with regard to website and social media content, which conditions can be treated within chiropractic, so as to not leave ourselves open to complaints by those trawling our websites and social media intent on persecuting our profession. Which conditions can we say we are able to treat using the laser without breaking ASA guidelines? Are these the same as the FDA approved conditions for each laser? That's a question I put to the president of the British Chiropractic, and I'm waiting for a reply. I don't know how you guys have found it in the US, and you know, as Jake said before, we're a little bit more of a conservative nature across here, so I don't know as yet how much it differs, but we will find out. Okay, one from Rose. I would be very grateful to find out how to use the Accelerate for an elderly patient of mine with poor balance and falls, and with severe DJD to cervical, spine, and shoulders, also for patients with rheumatoid arthritis. Dr. Rob Silverman.
Well, here's your Accelerate, and it's a great little toy. It's got 3 what we call FDA clearances. Love it extremely much, if you will. Now, for, whoa, sorry about that. My computer is acting crazy. Not supposed to do that. Anyway, so here it is. And poor balance, I'm a big proponent. I know we have a couple of guys here that do a lot of functional neurology. I make life easy for everybody. I go right to the cerebellum, and I work with them with the laser applied to their cerebellum. And I'll have them practice gait. I do things that are called locomotor lock-in. I'll have them walk in place, which is mimicking a cross crawl, putting a get in the cerebellum, because not everybody has a functional neurology background. So I try and keep it simple. Secondly, as far as DJD in the cervical spine, put it right in there. We'll get them to move it. Same in the shoulder. Let's not forget, let's also hit the brachial plexus on each side. Rheumatoid arthritis, yes, you can use the Accelerate, go right to their hands, but remember, rheumatoid arthritis, again, autoimmunity A, acquired adaptive immune system, and that comes from the gut.
Mm-hmm. Yeah, I think you did a perfect job there, Rob. The only other thing I would do is, in addition to the locomotor lock-in, is I would go back to basic Romberg's things, have them stand there, and just like you said, I get that laser right over the cerebellum as well too while they're doing it. What I like to do too is if they start, you know, kind of wobbling a little bit, it's just have them open up their stance a little bit to where they can balance, but they have a little bit of sway to where they're a little more stable. And then I'll give them a little feedback too, or I'll use I'll either with my hands, let's say, since you guys can't use a percussor, I'll just give them a little feedback as they're swaying while the laser is also being held over the cerebellum. And definitely, as you said, with the rheumatoid patient, I would also do those gut and vagus nerve protocols for sure.
Rob?
The only thing I add into that is I tend to go after the parietal lobe as well,
Sure.
purely because of body awareness. Because a lot of the time when we have, I suppose, stumbling, falling issues, you know, there's a lot of proprioceptive stuff going on there that we need to sometimes take a look at as well. And sometimes, you know, I'd also go after probably language comprehensive centers of the brain as well, especially in terms of kind of perception and stuff like that. That's all I'd add to that.
Mm-hmm. Yeah, that's all great. I think also because she's so old and she's got that DJD all over the place, you'd want to go and look at the feet and the ankles and knees and hips A lot of people are going to fall because they can't dorsiflex the toe, ankle, knee, or hip, so they trip over things. And so most people are going to fall when they're walking, and it's probably because they trip or slip on something. Also, because those long nerves are the first ones that are going to break down as you get older. You're often going to see old people lose vibration sense and their reflexes in the lower limb. So I might take the laser and go and work down on the feet and any of those long nerves that have got a long way to go and have got can be easily compressed and traction and sheared and all that stuff.
Hey, Simon, can I throw something out? And I'm not trying to take your time because you know I got to do another webinar. Mine's actually before yours, Kirk, but here it is. She said that this patient has DJD and rheumatoid arthritis. We all know that rheumatoid arthritis is an autoimmune condition. And this is a seed for another webinar, food for thought. DJD, we all call osteoarthritis, but I'm willing to put it out there and say, osteoarthritis is also autoimmune because it's the body's inability to manage and modulate inflammation when we're attacking the joints. 2007, the father of functional medicine said, you know what? This is autoimmunity because it's a aberrancy in our immune system attacking our joint. It's just a different area. So now I may have just added 3 hours to the webinar. That wasn't my intention. I just knew if I gave that before I left, I would leave the guys with the nuclear bomb and they would have to go like that. But, something for us to consider. But
right.
tied all in a tight bun, even if it's autoimmunity or not, we still, if we work the gut, we're able to have it. And without question, immunity is the conversation because with COVID-19, we learned one thing. We all better address the immune system. We all have to do it naturally because there's no vaccine or drug or anything like that down the pike. So when we say, what would you want to do? Well, pain's really good when you come back from COVID-19 because people haven't been treated. Obviously the quarantine 15 with like a Zerona. But how about the immune system? How about that conversation? Where do they go? They just don't know what to do. Right. So I think I just added another hour. I apologize, Simon, with all due respect.
Well, just okay. We'll do that another time. Does anybody else got anything else to add to that?
No, that's perfect.
Cool. There's a question come in from Jay Usher. Referring to the multiple lasers, are you able to use one head of the PL Touch on the brain while using the other head on, say, the gut? Rob Silverman, you want to start?
Absolutely. I love that idea. With the beauty of the PL Touch, which I have here, is the fact that you have two heads. So its inherent advantage is, number one, you can laser two different areas. Number two, you're also able to work the nerve impulses through an afferent and an efferent manner. So that's the advantage of the PL Touch. All the lasers are an advantage because they work so well. The Accelerate's really sexy, if you will, same size as my cell phone. And the EVRL, which I have a preference for because of the combination of the violet and the red light. So I hope I did that in an epigrammatic manner.
Perfect.
You did. Very good. Brilliant. Guys, look, I know that you guys have got a dash. I thoroughly enjoyed this. I think it's been the most enjoyable webinar that we've actually done so far. We've tried to sort of improvise with the current situation, and we've sort of tried, as I've said in a few emails to people, it's, as a company, we like to not stand still. Everybody's going through a very difficult time at the minute with the situation. But from my experience of having companies before, it's the ones that sit back and wait for other things to happen that the ones that tend to suffer a little bit more. And I know it's easier said than done, but you've got to keep pushing forward. We're going through this time. You've got to add other things to the portfolio. You've got to, start looking at extended scope of practice and what else you can specifically do. And one thing's for sure with the panel that we actually have here, the support will always be there from a clinical perspective, and we'll also try to help you from a commercial one as well. So on that note, I'd like to thank the four of you very much. I think this has been huge. I'd like to actually do a follow-up one if we can, maybe in a month or so's time. I think that would be a very good idea. Yeah, guys, thanks very much. Jake, Kirk, Rob, and Rob. Brilliant.
Yes, guys, that was a real pleasure.
Stay safe.
All right, thank you, guys.
Bye-bye.
Bye-bye.
Take care, guys.